We have done a lot of work with Idelalisib, starting from the original phase 1, and we continue to be part of the Idelalisib program. Highly effective agent. It's in follicular lymphoma and low-grade lymphoma in particular. It is now the next steps are trying to probably move it closer, earlier into the natural history of this disease. We're about to begin trials with Idelalisib and rituximab as frontline therapy for patients with low-grade lymphoma. So we hope to have that trial open in the next few weeks. But I think that's, again, getting back to trying to get away from the chemotherapy backbone that we've been stuck with for forever, from the beginning of time in low-grade lymphoma. The question here is really about tolerability. These new molecules are a very different paradigm for the treatment of low-grade lymphoma and CLL. In the past, you give someone some chemotherapy, you give it 6 months, you stop, and then you wait for the disease to come back. Now we're trying to convert these diseases to management in the same way we think of other chronic diseases like hypertension or diabetes. But that brings up issues, right? I mean, that brings up tolerability. A drug has to be safe to be given for that long in duration, and things that are okay, side effects that are okay. If their other things aren't working for them, when you're taking it frontline, they have to be that they may not be okay, right? Someone may not be willing to put up with some of these grade 1 or grade 2 toxicities, and that's one of the questions we hope to get to. Clearly that we're learning about how to partition our patients with the different drugs, with Idelalisib, with ibrutinib are the two that come to mind. In looking at patient populations, so we know now that both these drugs work in 17 P-deleted patients where we previously had pretty poor outcomes. That's the good news and the bad news. The good news is that people are responding. The bad news is, unfortunately, we're not seeing a plateau in the survival curves, and they're coming down. So finding ways of combining these agents with other drugs, whether it be an antibody or perhaps other small molecule, is important. And I think the next wave that we're looking at is also back to some of the things we were talking about before. So we need a drug that's not only that effective, but is tolerable if we're going to move it frontline. So developing some of these second and third generation drugs that look like they have a very clean toxicity profile, such as TG Therapeutics drug with a delta inhibitor that we've done a lot of work with. So far, that looks like it's a very clean from a toxicity standpoint, and that might be an advantage. The other issues that we have to deal with is, again, we're starting to see resistance. So we know that, for instance, in the CYS481 mutation that occurs in patients with CLL, we know that's an issue. We also know that we're less clear about in the PI3 kinase inhibitors about what's the modus of the resistance. There are some descriptions of increase, or at least utilization of other isoforms of PI3K like alpha in mantle cell lymphoma. That's been described. So figuring out how broadly to hit these diseases and maybe not so narrow, work in combination with other agents, I think is a really important issue that we're going to be tackling for the next few years. It's got to be good news that some of the new both Idelalisib and ibrutinib, in that you think about certainly in the CLL population where there's good data that the aggressive regimens such as FCR really aren't tolerable just from a cytopenia standpoint. These drugs don't have those problems, and so being able to deliver a very highly effective therapy in patients that are intolerant of other regimens such as the elderly, that's I think it's a really important milestone for them.